I'm Thomas Baldrick here at ASH 2014. Happy to be joined now by Dr. Craig Moskowitz from Memorial Sloan Kettering, here to talk about the Aethera Trial. Thank you, sir, for
You're
coming
welcome.
by. So why did you take on this study?
So this is a patient population that's curative in the relapse setting. Back in the mid-90s, early 2000s, there were two randomized trials showing that a stem cell transplant for patients with relapse disease improved survival, and about 50% of the patients were cured. Unfortunately, those survival curves have been plateaued now for almost 2 decades, and we have made very little inroad. Back in 2009, we began studying brentuximab vedotin, which is a antibody drug conjugate to CD30, which is on the surface of Reed-Sternberg cells, the malignant cell in Hodgkin lymphoma. We wrote this particular study, the Aethera study, in late 2009. It was evident at that time that brentuximab vedotin was likely going to get approved in Hodgkin lymphoma for patients where a stem cell transplant fails. We knew that the median survival of patients who failed a stem cell transplant was between 24 and 30 months. So we wrote a large randomized multi-center multinational study comparing everybody was transplanted, and if those patients were at risk to relapse, and these are predefined risk factors, they were eligible to partake in a randomized trial. In fact, interestingly, the only placebo-controlled randomized trial ever done in Hodgkin lymphoma. Patients got 16 doses of brentuximab vedotin versus placebo, with the primary endpoint being 2-year progression-free survival. At the end of the day, 65% of the patients who received brentuximab vedotin appear to be cured. And the reason I say cured is that relapse rates after 2 years from stem cell transplant is actually minimal. And 45% of the patients who receive placebo are likely cured. So there's a 20% absolute difference in freedom from progression. At this particular point, there is no difference in overall survival. That's a complicated story. It turns out that the median survival of a Hodgkin lymphoma patient in 2015 that fails a stem cell transplant is close to 4 years, not 28 months. And the reason for that is a lot of new medicines for Hodgkin lymphoma, including brentuximab, including HDAC inhibitors. And at this meeting, I'm sure your audience knows that the checkpoint inhibitors are also active. They are nivolumab and pembrolizumab in patients with Hodgkin lymphoma. So it's too soon to look at overall survival. However, what's undeniable is that if you're in remission at 2 years after a stem cell transplant, you will likely be cured. So 65% of the patients on the BV arm are in remission at 2 years. 45% of the patients on the placebo arm are in remission at 2 years. So from my point of view, once this is published, it'll be practice changing.
How has it changed since you started this in 2009, your perspective on where we are in helping these patients?
I think the major thing is that with all the new medicines, that patients are living longer after a failed stem cell transplant. It's actually a very good question because there are now patients who are getting brentuximab vedotin earlier on in their treatment. And are they going to get it after a stem cell transplant if their first treatment doesn't pan out? That's a matter of debate. But what's undeniable is that we're curing more patients in the relapsed and refractory setting. And I've been transplanting patients with Hodgkin lymphoma since 1994. Every single study in the aggressive lymphomas, including diffuse large B-cell lymphoma, the T-cell lymphomas, and Hodgkin lymphoma, every study is negative, comparing A versus B. This is the first positive study in this setting. So by definition, it met its endpoint and it should change management.
What's next in your research?
So I'm very interested in combining brentuximab vedotin with the checkpoint inhibitors, and I'm trying to marry companies together. Whether or not that's going to happen is unclear. It looks like it's going to happen. And our goal is to combine these two treatments because they're both non-chemotherapeutic choices, and to give it to patients prior to a stem cell transplant. It is hoped, now I can't say this is going to happen during my career. I think I got a good 15 or 20 years left. However, I think the real goal is to eliminate stem cell transplant altogether in Hodgkin lymphoma. And could that happen? I believe it's possible. but we're a number of studies away from that.
Congratulations
Okay.
on your efforts, and best of luck fighting the good fight going forward.
Okay, well, thank you so much. Appreciate it. Thank you.